Funding for this program was provided by the Annenberg CPB project.
Sometimes, as we go through life, we master our experiences. Sometimes we don't.
Voices come out of nowhere, whether I'm on medication or not. Sometimes they come really bad, and sometimes they don't come at all. It's just once in a while. And when they come, they sound as real as you or I.
Leslie is a paranoid schizophrenic. He's heard voices since he was 8.
Or I sometimes hear little children talk to me, or I hear my mother's voice or my grandmother. And anytime I say something about Jesus, my grandmother says, "Oh, Lord." And sometimes, like, I had a pastor, and he said to put the voices to the test, and I would say, "Confess unto me that Jesus Christ is the Son of God." And the voices would say, either they would either confess it or they wouldn't. And if they did, I would know they're on my side. And if they didn't, if they did, I would know they were on my side. And if they didn't, then I would know they were against me, and I would rebuke them. And generally, if you talk to them in a certain way, they will leave you alone. But it takes a lot of strength and a lot of suffering to get up to that point.
Leslie's experience dealing with the symptoms of schizophrenia is quite typical. In this program, we'll explore what it feels like to live with this disorder, what factors are believed to contribute to its onset, and what can be done to treat it. The schizophrenias are a group of disorders often so disabling that they're considered the ultimate in psychological breakdown. The symptoms are so extreme that until recently, patients who had schizophrenia were nearly always put into mental hospitals. Today, about 10% of people with schizophrenia still need to be hospitalized for their entire lifetime. But both within and outside of the hospital, a large majority of these individuals can now be treated. This enables many of them to make the transition back to the community. Still, there is no escaping the fact that the schizophrenias can be a crippling and devastating group of disorders, frightening to those who suffer from them, and often baffling to those who study and treat them.
Well, I think of Christ suffering on the cross, or someone suffering. I'm always suffering.
You're always suffering.
Because I think that I'm God, and that I'm going to, by being a schizophrenic and going through this hell, it's making the new world. Other people are helping. Everybody's doing their part.
Somehow I just keep thinking I'm the devil.
Mm-hmm. And you say you also hear some voices that are very
troublesome. I'm talking to
you.
them.
Are you experiencing them now? Do you hear the voices now?
Just time and space.
Schizophrenics like Cindy and Mary Jo indeed seem to be living in another time and space. They experience the world as an unsafe and frightening place, filled with voices and hostile forces looking to take control of their minds and bodies. About 1% of all Americans will develop schizophrenia in their lifetimes. People with schizophrenia occupy about 30% of all hospital beds in the United States, medical and psychiatric. The schizophrenias appear in virtually every culture in the world. There are two onset patterns: chronic, in which the disorder develops gradually and is long-lasting, and acute, in which symptoms occur suddenly. In this program, we'll see examples of both types. Dennis Shulman is a psychoanalyst and professor at Fordham University, where he teaches abnormal psychology.
This group of disorders is characterized by gross distortion of reality, withdrawal from social interaction, and disorganization and fragmentation of a number of very essential psychological processes, particularly perception, thought, and emotion. So that schizophrenia affects all of those activities. Schizophrenia is the most profound, the most puzzling, and the most controversial within the field of the disorders.
Schizophrenia can only be diagnosed by very careful examination and observation of the patient. In particular, the patient has to describe certain unique and unusual kinds of experiences that other people never encountered. And the three types of symptoms or unique experiences that people with schizophrenia have are unusual thoughts that are not shared by others, such as the belief that the person is being pursued by the FBI or by the CIA, or that their food is being poisoned by someone in their family. These are delusions.
I get paranoid. I'd be afraid of people, what they had to say to me, because after I was afraid they condemned me. And I felt being ridiculed and confused, and like I was condemned all the time. Even if I didn't do something wrong, my parents would condemn me. And that would draw a setback to my condition. And it would cause me to see things that weren't there.
A second type of symptom are unusual perceptions, hallucinations, and most frequently hearing voices, auditory hallucinations. Most commonly, these voices are speaking directly to the person. But individuals who suffer from the symptoms of schizophrenia can sometimes describe hearing two or more voices talking about them in the third person. And this is a particularly striking and unpleasant kind of symptom of schizophrenia.
At 19, Leslie obeyed a voice that cost him both his feet.
I was about to walk out and I heard a voice. I think I told you this too. It said, "Where are you going?" You know, I said, "I'm going home." He said, "You got no home to go to. Nobody wants you anymore." This is what the voice was saying to me. And I went to walk out the door again. He said, "Nobody wants you." And he said, "There's only one way out for you, and that's through that window." You know? So I just gave up. So I stood at the window and I took a cigarette and I lit it. And I saw the smoke go up after lighting the cigarette. And the voice said, "There, that's when you should have went out the window." So I walked around the room and I ran and I was about to jump out the window. And I stopped and I said, "No, that's something my brother would do." As if my brother was influencing me in some way to do this so that I would splatter all over the street. So I stood with my back to the window once more. I lit the match and I saw the smoke go up and I fell backwards 5 stories out the window. As soon as I was on this angle here, I blacked out. I didn't see a thing. I woke up the next day in the hospital, tubes all in me, and the bones in my feet all busted up. My wrist was busted. My face was like this. I was lucky to still be alive. Because I didn't really go out the window to kill myself. I went out the windows, I guess you can say it was because of misunderstanding. And what a misunderstanding that was.
The third type of symptom that may be present is disorganization of thought and speech.
So that the thoughts are disconnected, and when a person speaks, there's either a great deal of tangential, circumstantial, rambling kinds of lack of connectedness of one thought to the other.
Like in the daytime, when I be outside in the sun, I used to show my friends things that they hadn't seen before, like the halo. See, like the halo, when I was 19, when I was preaching, and I had my trial sermon, I used to see a little light over my shadow on the ground in the daytime. And then now, ever since then, it's like a light coming further down over my body, around my shadow. It's over my body, but around my shadow, and I see the light, which is your halo, I mean your aura. And that's why everybody can't see that. But if you see, you got something to do with the drugs too, we say. And now I don't know what's for real. I know what I see, but I don't know if it's for real or not. And so that's why you say people are different. And see, like that anointing, like see, like sometimes when I come outside, I can see when I look at the trees, the wind starts blowing. Cause we know we get oxygen from the plants, and we get them carbon dioxide. And so it's the wind usually blows sometimes, but it don't blow all the time. Like when I'm in the house a long time, it blows real strong.
all the time.
Janine, who is a paranoid schizophrenic, has convinced herself that she has overcome this disorder. She now clings to the idea that she has post-traumatic stress disorder, seeing it as a less devastating and more acceptable diagnosis.
See, post-traumatic stress, which I have now as a diagnosis, I see reflections of realization from what happened in my life. But the paranoid schizophrenic would be like an illusion that I'd seen. But no one else could see it. No one could realize what I was going through.
It's not surprising that people will try to take on the designation of some other kind of disorder or feel or try to claim that they really don't have schizophrenia, that they're normal, and that the family or the doctors are all wrong or have a problem, that they don't have a problem. And it's really an attempt to avoid both the social stigma, the unpleasant kinds of attitudes that have been attached to schizophrenia over the centuries, madness and so on, and also to try to escape from, at least temporarily, this feeling of helplessness and passivity, abject passivity and being out of control.
These paintings by a 28-year-old schizophrenic woman show many qualities typical of the artwork of schizophrenics. The world is depicted in the distorted and unreal way that people with schizophrenia often view their surroundings. In the paintings, inanimate objects take on human characteristics, and human body parts appear as animals. There's frequently a ghoulish tone to the art, with heads empty and features such as mouths or eyes partially gone or completely missing. Often the artwork presents a confusion of sexual identity, and a robot quality in the figures is not unusual, reflecting a patient's feeling of being driven by forces out of his or her control.
What's it like living here? Do you know where you're living?
Yeah, I'm living now in Cameron State Hospital probably forever, or for a while at least, until I get a partner or a work experience or some lift or break in my life.
Jeff has a diagnosis of schizophrenia, chronic undifferentiated type at this point in time. Prognosis, it's kind of a mixed question. He is almost ready to go back to the community in our judgment. The kinds of things that bring somebody to a hospital like this at this day and age again is where they're a danger to themselves or others, or they're what we call gravely disabled, unable to care for themselves. Jeff, if he doesn't get lost, can usually care for himself pretty well, and he's certainly not a danger to anybody.
I like mustard on my hot dog.
I like mustard on my hot dog.
All right, very good. The teacher corrected all the math workbooks.
The teacher corrected all the math workbooks.
Good. The study of genes is called genetics.
The study of genes is called genetics.
Great. The world's population...
When Jeff returns to the community, he will live in a sheltered setting. This memory exercise is one way to assess how high-functioning he is, and specifically, what memory he has lost or gained. Memory loss accompanies schizophrenia, particularly in some chronic patients. It may be a side effect of medication, or the result of brain damage, or a general lack of motivation.
The yellow big sponge absorbed the spilled milk.
The yellow absorbed sponge spilled milk.
Okay.
As the difficulty and number of words in the sentences increase, Jeff has trouble recalling them with any accuracy.
Jim had several interviews at banks and insurance offices before he was hired.
Hank had several good interviews at the bank yesterday for interviews in offices.
Okay. Jim and Mary live upstairs from me and frequently come down and have pizza for dinner with me.
Jim and Mary live together with me, and usually we have pizza on Thursday.
Mary checked out...
My mother likes to paint. She likes to read. She likes to eat. She never smokes. Neither does my father ever smoke. And when I started smoking, I was very bad to my parents, and I went to the backyard and started smoking, which would be on their permission, for which I might have paid a dear price, even maybe my life, for smoking. But I started to change the subject, but my parents and I get along. We never argue. And we always vote the same way.
The thoughts can be very bright and kind of be connected, but there's a looseness there in terms of how he comes to the point. He'll have a thought of some kind that kind of take him far afield from you at any particular moment, and it makes it difficult to follow.
You always vote the same way?
Yeah.
Yeah? You want to tell me how you vote?
How do I vote? Or who? My favorite person I ever met was Abraham Lincoln, but of course I can't vote on him. He's gone 400 years ago. He was a Republican, of course, our grand old party.
Did you actually meet him?
Oh, no, I never met. No, I'm not at all. Never met Abraham Lincoln except through books or surveys.
He also describes some thought disorder in terms of meeting or talking to the past president. Then kind of quickly took it back, but at times he will stay and affirm with a thought of that kind for some period that he in fact does know famous personages and has talked with them, and that they sent him messages and things of this nature.
I heard you used to work at the post office.
Yes, I used to be a postal clerk carrier for the Lamona Annex at Raymer Street.
Was that right around then you realized that you had an illness?
No, I wasn't right after I got hired. It was about a year after I decided I'm getting a little schizophrenic, and I left my job to go to Kentucky to preach the gospel. And that didn't work out too well, so I came back home.
You're hearing voices?
No, I don't usually hear voices. It's not my phenomenal problem.
I thought one of the doctors told me you did hear voices.
That could be that I hear voices. I told him that, but I don't usually hear voices.
Even though gross distortions of reality, such as the auditory hallucinations chronic patients like Jeff suffer from, are typical in schizophrenia, Professor Schulman emphasizes that there is another side to the disorder.
Maureen came to me in an emergency. After seeing me for a few months, she called me and said there was somebody chasing her with a knife, and she was terrified. She came up to my office, and it became very clear in a very short time that this was a paranoid hallucination, that there was no one in fact chasing her with a knife. It was her fantasy, and it was a rather concerning thing that she might throw herself in a subway pit to get away from this man with a knife, or throw herself off a building. Not exactly commit suicide, but in an attempt to defend herself in the face of this hallucination, that she might hurt herself. And so it was important for us to, me and the patient, to talk about hospitalization. I took Maureen over to the emergency room at the local hospital. And in the emergency room, we were waiting in line. And as we approached the desk, the woman who was supposed to receive us to do the intake was on the phone. And it was clearly a social conversation. And I could tell Maureen was getting more and more frightened, and the woman was going on with her friend and ignoring her and me. At which point Maureen started shrieking at the top of her voice in the most enraged and hostile way I've ever heard anyone screech. It's what one would describe as psychotic rage. And in the middle of this shrieking, she turned to me and said, "Dennis, don't worry, I'm okay." And then she went back to screeching. Now, I do not have the sense that she was faking the psychotic rage. But I think more than anything else, and this is the most instructive thing when working with schizophrenic patients, is that even in the middle of her most terrified, enraged, psychotic episode, she was taking care of me. There was a part of her that was healthy. There's a part of every schizophrenic, even this patient, who's in a horrible situation at this point. Every schizophrenic, there's a part of them that is non-schizophrenic. And I think that more than anything else, that's important to keep in mind as we talk about patients who might seem very strange, exotic, or bizarre. I want to talk about some of the misconceptions, the popular misconceptions that people have about schizophrenia, because they are massive, typically. First of all, the issue of violence. Many of the textbooks in abnormal psychology describe an important piece of information, that the fear of violence within schizophrenia talks more about our fears as normal or non-schizophrenic people than it does about schizophrenia itself. As you will see, the most salient characteristic about schizophrenia is not violent, the violency or the maniacal violence that schizophrenics experience. It's really withdrawal. And therefore, schizophrenia by itself does not necessarily mean violence.
Of course, sometimes people with schizophrenia, particularly the acute form, do commit violent acts. When schizophrenics act violently, their crimes tend to be unpredictable and highly publicized. This leads to a pervasive misconception in society that people with schizophrenia are by nature violent.
Another one that is very much an omnipresent misconception is that schizophrenia is sometimes misunderstood as multiple personality. In schizophrenia, the split has to do with an integrated personality. The person is fragmented within one personality. Whereas when we talk about multiple personality, the person has two or more intact personalities. So a schizophrenic is not somebody that has 2 or 3 or 4 separate personalities. They're somebody that evidence split in their one personality.
In other words, in the schizophrenic, the split represents a disruption in the connections between thoughts, feelings, and behaviors that are present in an intact personality. For example, in a non-schizophrenic, sad thoughts and feelings will normally lead to behaviors which reflect those thoughts or emotions. But in people with schizophrenia, thoughts or feelings will often lead to behavior that seems out of place or inappropriate.
The last point I want to make about misconceptions has to do with homelessness and schizophrenia. Unfortunately, this is an issue that's become very controversial in the last few years with the enormous rise in the homeless. And while certainly a proportion of the homeless are from the deinstitutionalized schizophrenic population, some of the bizarre behavior you see among the homeless sometimes is an effect of being homeless, not the cause for homelessness. If you think about what the phenomenological experience is for a person living on the street, I think everyone in this room can understand that that's a significant current life stress.
Why do some individuals end up with schizophrenia? Why are some people more vulnerable than others? Dr. Nancy Andreasen, research scientist at the University of Iowa, emphasizes the multiplicity of factors that may lead to schizophrenia.
What we know about the causes of schizophrenia is that there probably isn't a single cause or a single mechanism. If you review all the evidence that has been accumulated looking at genes, environment, brain function, and so on, it suggests that this illness is probably what we like to call multifactorial, or produced by a variety of different factors. It's probably analogous to other illnesses like diabetes and hypertension, whole host of things where you can have a mix of stress, diet, heredity, a variety of things that interact together and cause a person to develop diabetes, to develop high blood pressure, or in this case, to develop schizophrenia. Some of the different factors that we talk about with schizophrenia are things like a genetic predisposition, birth injuries early in life, infections early in life. Those are probably the main ones. Psychological stress may also be relevant, although less well studied.
Causal theories of schizophrenia have been greatly advanced by the use of modern brain imaging and scanning techniques, like CAT scans or MRIs. With these new technologies, scientists can get a closer look at the brain structure and identify abnormalities which may be related to schizophrenia. Most of the abnormalities are more likely to be seen in chronic, not acute schizophrenics.
When we think about what could go wrong with the brain in schizophrenia, there are two components. One is the structure of the brain, which you can see with the naked eye, or you can see with imaging techniques like CT and MRI. The other thing that can go wrong is the function of the brain, how it actually works on a day-to-day level, making decisions and thinking and feeling. We can see some structural abnormalities in patients with schizophrenia. The commonest, the most consistently observed, is enlargement of the ventricular system. That's been seen in approximately 45 or 50 out of 60 studies that have been done using CT scanning.
Here we're looking at a 3D reconstruction of these brain structures. The brain, which is around here, has been cut away, and we're looking at what's deep inside the brain. These blue things here are the ventricles, and again, these are just huge ventricles. If we we're looking at a normal brain, it would look like a little tiny blue worm here, but instead they're very enlarged.
Scientists use other techniques to look at brain function. The common ones are either SPECT or PET scanning. Both of these techniques have revealed functional abnormalities or differences in activity in the prefrontal cortex of acute schizophrenics. The prefrontal cortex is that part of the brain devoted to thinking, decision-making, and planning. On the biochemical level, scientists are looking at the neurotransmitter dopamine. It is thought that schizophrenia might be a result of excessive dopamine activity at particular sites in the brain.
The dopamine hypothesis is based on a couple different lines of evidence. One line of evidence is that the drugs that we use to treat schizophrenia, which we call antipsychotics or neuroleptics, those drugs have been shown very clearly to work by blocking dopamine transmission. And specifically, they block dopamine receptors and a subclass of receptors known as the dopamine type 2 receptors or D2 receptors. It's been shown that the more potent the drug, the more powerfully it blocks dopamine receptors. That suggests that, these drugs are correcting an abnormality and that the abnormality is in the dopamine system. So that's one line of evidence from pharmacology and treatment. The other line of evidence is from observation of what happens to people when they take drugs that increase dopamine transmission, particularly drugs like amphetamine or cocaine. We call them dopamine agonists. Those drugs have a strong potentiality to make people have symptoms of psychosis. Amphetamine in particular produces in some people a psychotic syndrome that looks very much like schizophrenia. So we can observe that if you increase dopamine in the brain, you can make people psychotic. And that, again, suggests that then this is possibly a mechanism that produces schizophrenia.
Another important biological factor that has been studied extensively is genetics. Evidence in this area comes from family studies, twin studies, and adoption studies. The family studies have shown that if a person has schizophrenia, the rates of this disorder in his or her immediate family are about 10 times higher than in the general population. Twin studies look at dizygotic twins who develop from separate fertilized eggs and are related genetically only as much as ordinary siblings, and monozygotic twins who develop from a single fertilized egg and have identical genetic material. These studies have found that schizophrenia occurs more frequently the closer the genetic relationship. But even the twin studies leave unanswered questions.
The twin studies are extraordinarily interesting, and they're cited all the time as the major support for the genetic contribution to schizophrenia. But from my perspective, they've also been instructive in making me realize that there must not be a strictly genetic explanation. For instance, if you take a look at the data on monozygotic twins and the concordance rates in schizophrenia, you see rates of 40 to 50%. But and with the dizygotic twins, concordance rates of only 10%. Well, that certainly sounds like it's powerful evidence for a genetic contribution to the schizophrenia, because the monozygotic twins show 4 to 5 times a greater degree of concordance than the dizygotic twins. But what about the other 50%? That's what puzzles me. When you see monozygotic twins have a 40 to 50% concordance rate, it means that there are a great many pairs of monozygotic twins in which one twin becomes schizophrenic and the other one doesn't. If schizophrenia was simply explained by the genes and carried in the germplasm, then you would expect a 100% concordance rate in monozygotic twins. And the fact that you don't get that indicates that there are other factors that may be critically important in the expression of the disease.
So as Dr. Katkin explains, even if twins do carry the genetic basis of schizophrenia, environmental influences may still play a role in whether or not the disease develops. For example, experiences such as war.
Many young people develop schizophrenia or the symptoms of schizophrenia for the first time when they're in military service. Part of the reason for this is that there are certain stressors that they are experiencing or encountering for the first time, being away from home, living in a barracks with many other young people, having to deal with the rigors of military life. And so the stress, when combined with a pre-existing vulnerability, can often trigger the illness for the first time.
Randy, a Vietnam veteran, says that it was combat that triggered the onset of his schizophrenia.
But I've had this problem ever since Vietnam, and the voices still, the medication keeps it under control as to where I don't become a suicidal or homicidal, which I have both those tendencies to do. Usually the homicidal, and they just taught me too well, and I've hurt a lot of people.
For those veterans who see combat, there's even additional stress that they have to deal with. And so it's not surprising that being exposed to combat situations and atrocities of various kinds in Vietnam led many people with the vulnerability to schizophrenia to break down and to have the first onset of their illness.
It isn't only under the stress of war that the symptoms of schizophrenia can manifest themselves. The challenges of new adulthood, which occur in the late teens or early 20s and often involve loss of emotional support, may contribute to the onset of schizophrenia in a vulnerable person. Moving away from home, going away to college, a first sexual encounter, all of these may act as triggers for the initial schizophrenic episode. Interestingly, onset for schizophrenia at this age, under 25, usually applies to men. Onset for schizophrenia in women is later, after age 25. There are other psychological factors that may contribute to the onset of schizophrenia. Childhood experiences, unconscious conflicts, the nature of the family, all have been thought at one time or another to be causal factors. One traditional, if controversial, view has been the concept of the schizophrenogenic family, in which overprotective or rejecting qualities in the parents, especially the mother, are thought to be associated with the development of schizophrenia in the child.
The first theory was advanced by some of the earlier psychoanalytic theorists, and it talks about the schizophrenia as a result of certain family dynamics. It's what we refer to as the schizophrenogenic family, or the schizophrenogenic mother or schizophrenic father, referring to schizophrenia caused by mother, father, family. There is clinical and research evidence to indicate that there is some validity, again, in this theory in some cases.
This idea that the family constellation and its dynamics is the major cause of schizophrenia has in recent thinking been modified. A broader approach to the role of the family and its interactions has been developed.
An important question that's come out of more modern thinking in terms of psychopathology and psychology is whether possibly that an impairment in a child can cause a family to react in a disturbed fashion. That it's possible that it's not all a one-way street where the patient is a passive recipient of the family disorder, but that the family in some ways is reacting to the disorder already evident in subtle forms in the child.
Dr. Ann Silver of Chestnut Lodge amplifies the notion of these complex family interactions.
What's more alive than blaming the other is looking at the effect that the schizophrenic individual or the pre-schizophrenic individual has on the family. Denise Ford, who's on the medical staff here, did her PhD thesis on the subject, and it was really a fascinating piece of work showing how the person who's struggling with early and developing schizophrenia alters the communication and mood pattern in the family itself. So there's a terrible resonating that takes place as things kind of fall apart. As the person falls apart, the effect of that on the other family members, the grief, the guilt, the apprehension, the desperation, I think, really, that then evolves in the tragedy of this illness.
What there is good evidence for is that the family, just as any other situation, and where a person with a serious, disabling, and often bizarre and unpredictable illness is living and interacting, the family situation can be affected, can be seriously affected by this kind of an illness. This is a chronic, disabling, and difficult to manage illness. It's difficult for the patient, it's very difficult for the family, especially when the young person involved has had a very promising earlier life and then suddenly is afflicted by this illness and becomes disabled. So the effect it has on the family is to make the family experience great amounts of stress.
I would say so. I think that that time he was more or less separated from the family and wanting to be secretive about what he was doing.
Jeff's parents discussed the disruption in their family existence when they first realized that their son had schizophrenia.
In the very early stage, of course, we were entirely, the whole experience was so new to us, and we certainly did not connect the experience with schizophrenia. That's something that we learned about as time went on. But the early experience was extremely scary, and with having no background in this illness, why we just didn't know how to take it. But as time went on, we realized that there was something wrong and that there was illness involved. And we did as much as we could to learn about the illness. And for months after, we tried one psychiatrist after another, and no one seemed to be able to help directly.
Well, Jeff sort of acted up at one point, like, I forget exactly what he did, but he acted crazy. I know that's the only way to describe
psychotic
it. Psychotic, and we took him to the doctor said he should be hospitalized.
But gradually, we realized that it was a full-blown case of schizophrenia, and we realized that we would have to deal with the illness.
During the 12 years that Jeff has been at Camarillo State Hospital, his parents have visited him every Saturday, giving him the kind of support that seems to be crucial during the course of this disorder. So too did the family and friends of David, a former patient at Chestnut Lodge, who is now living and working in Boston.
Without support, there's no way a patient can make it. You can't pull yourself up by your shoestring. And that was the one thing I was always aware of when I was ill, was my intense gratitude for people around me. I couldn't express it, but when I'd go to bed at night, I'd be thinking, what would I do if I was on the streets? And the most agonizing part of my illness was when I was informed that I couldn't live at home anymore, when I was in the hospital. And I thought, I'm going to have to make it on my own. It didn't occur to me that I'd have so much support. I didn't think there'd be people there for me. And as it became gradually more and more apparent to me that there were going to be people there for me, I became more and more optimistic about my future. There was never a question that I would stop fighting. I just thought I'd lose the fight.
There is nothing that happened in the field of abnormal psychology, particularly in the field of work with schizophrenia, that has revolutionized the work more than the treatment, the drug treatment of schizophrenics. Up until this point, up until the point when drugs were introduced in the 1960s, 70s, and 80s, the treatment of choice really was electroconvulsive therapy, what is colloquially referred to as shock treatment. Shock treatment is almost never used in schizophrenia any longer. It's used in other disorders more frequently. Drug treatment has radically reduced the length of hospitalization. So, for example, in the 1950s, the average schizophrenic would stay 353 days in a hospital, in a psychiatric hospital. In 1960, at the beginning of drug treatments, the average schizophrenic would stay in a hospital 113 days. Tremendous change. And in the 1980s, the average hospitalization for schizophrenia is 18 days. You can see how enormous those differences are. Drug treatments remit the episode of schizophrenia within weeks for about 90% of schizophrenics. Now, that doesn't mean cure schizophrenia. It means that it remits the symptom, the episode. And it also has been shown that relapse rates are about half when someone is treated with drugs when you compare with somebody who is not treated with drugs.
The SPECT scan offers a valuable opportunity to see how drugs affect the prefrontal cortex in acute schizophrenics. This SPECT scan shows the activity in a normal individual's brain when carrying out a cognitive task. The prominent red spot in the right frontal cortex indicates that there is activity going on in this part of the brain that's used for planning and other so-called executive functions. In the unmedicated chronic schizophrenics, there is no red spot in the top right. This means that the prefrontal cortex has not been activated in these patients. Once on phenothiazine medication, the scans of chronic schizophrenics show a marked difference. Although the scan does not show the prominent red spot that was seen in the normals, it does reflect more normal functioning in that part of the brain. For most medicated patients, the symptoms of schizophrenia can be reduced markedly with antipsychotic drug treatment. The following patients are presented off and then on the phenothiazine or antipsychotic drugs. Although the medication doesn't remove the symptoms completely, as you'll see, it can make possible a dramatic change in thought process and behavior.
Have you had any feelings that people were against you, or no, nothing like that?
I don't like my eyes coming apart.
Your eyes, yeah. What about your hair, Tom?
One time I got the idea that the funny papers were trying to drive me insane. I'd read them and then I'd get all hypertensive about that. I didn't necessarily know anything that was in there that was plotted, but they'd upset me greatly.
Okay. They're pulling out your guts and insides and sucking you dry. Who's they, do you know?
My sisters and nurses, and I can't see who really. I don't know who gets up there and does it. But I know that my sister's done some bad things.
You actually feel your insides being pulled out?
Yeah.
Is it painful?
Yeah, it scares me. At the mall, I was nuts then. I was kneeling and praying
in public,
right outside this restaurant at the mall there. And the guy, one of the chefs just came out and stood there and looked at me and turned around and went back in, and I continued to. There was a time where they were really making me kneel and pray a lot.
The main effect of the drug are significant, but like every drug, whether we talk about aspirin or antihypertensive medication or any drug, drugs have side effects. The side effects in the case of the antipsychotic medication typically are the dryness of the mouth, the stiffening of the muscles, the tremors of the hands and the legs, and the worst one by far is a condition called tardive dyskinesia. What tardive dyskinesia is a disfiguring disturbance of motor control, particularly in the face, with involuntary movements, smacking of the lips, chewing, that goes on. And sometimes people misinterpret those kinds of symptoms as part of the schizophrenia, when in fact it's a byproduct of the drugs that were the treatment for schizophrenia. The problem with tardive dyskinesia, the horrible problem about tardive dyskinesia, is that people can develop it even if they're no longer on the drug, and there is no way at this point to reverse it. The main effect of the drug, the thing the drug does do, is that in many cases, not in all, it normalizes the person's overt behavior. It also normalizes their thought process, and it increases their ability to communicate. But again, I cannot emphasize enough that drugs do not cure schizophrenia, they treat these symptoms. Important ones that make it possible for the person to function at a much higher level than they would without the drugs, but it's not a cure in the typical sense of that.
It's like that Charlie Brown character has his dust blanket, and has his blanket, and it's a security for him. And it's like the medication when you first get on it, it's like a security for you. But after a while, you notice that it doesn't really do any good. It's not stopping the voices. It's not that the voices come all the time, but I don't know where they come from. Sometimes I hear friends, sometimes family, sometimes my friend Paul talks to me.
Leslie's voices are likely to plague him for the rest of his life. But for many patients with schizophrenia, medications do provide a means for effectively relieving the major symptoms, allowing a return to living in the community at some level. In addition to medication, there are a variety of psychosocial interventions that can help ease this transition from in to outpatient. They include family therapy, which focuses on improving faulty communications among family members and can reduce relapse rates, group therapy, in which several people with schizophrenia meet with a leader and work together on social interactions and relationship skills, and milieu therapy, an inpatient program that provides a therapeutic community in which patients share responsibilities and decision-making with the professional staff, preparing them for life outside the hospital setting. At the Los Angeles Veterans Administration Medical Center, the skills training program also addresses issues of independent living, such as managing medication and its side effects.
Yeah. What are some of the things you think you might be looking for to tell you what the effect of the medicine is?
Hypertension.
Well, now, think about the medicine you're taking. What medicine do you take, for instance?
Mellaril.
Okay.
Well, I did.
All right. So with Mellaril, you would be looking for the effect of Mellaril on you, right?
Yeah, sleepiness.
All right.
Anxiety.
What about anxiety?
I get it when I took Mellaril.
Okay, Mellaril made you anxious, so it was kind of a side effect that you were having? Okay, so what you're saying is that one of the things you'd be monitoring is the side effects of it, right? What else would you be monitoring, Randy, about your medicine?
Well, along with my medicines, I have to take a lot of medicines, mainly Sinequan, Navane for voices, Sinequan for depression and schizophrenia. I take Cogentin, I take Klonopin, I take Clonidine, and with all these different medications, I take them at different time schedules. And one of the things that I always look for is how my appetite is, whether or not I slept well or not, drowsiness, if I'm tired or not, if I'm alert or not, whether I'm constipated or not.
Besides helping patients to manage the panoply of drugs they may be taking, the skills training module helps them learn to talk to their doctors, make social conversation, and do such everyday tasks as plan and cook dinner. These are the same executive functions of the prefrontal cortex that the SPECT scans seen earlier in this program showed to be abnormal in schizophrenic patients.
Social skills training is a way of helping the patient learn how to cope. Many of them have cognitive difficulties in that they are not always able to process information effectively. They may get part of a message, they may get the message distorted, they may not get it at all. So with a systematic kind of social skills training, we can teach them step by step, piece by piece, how to get the entire message and help them organize and maybe develop some appropriate responses.
It's important not to think of a person as being permanently suffering from schizophrenia or being schizophrenic. A person can go for hours or days or weeks or months with or even without treatment and not have these disabling symptoms of schizophrenia. So treatment to be most helpful to people and to enable a person to be effective in getting back on track in life, treatment has to be keyed or linked to the current state of the person.
When they come to us, we can teach them both how to improve the way in which they communicate and also how to identify the kinds of information that people need in order to be able to help them. So, for instance, with the doctor, if they're not feeling well, they can say to the doctor, well, doctor, I'm having trouble, I'm shaking a lot, I can't write, I can't hold a cup of coffee, and it really bothers me a lot, and I would like for you to fix it, to do something about it. That kind of response is far more likely to provide the physician with some real concrete information about the extent of the problem, how long it's lasted, and in what way it's disabling or discomforting to the patient.
In addition to psychosocial skills training and to medication, various kinds of psychotherapy are used in the treatment of the schizophrenias. The goals are to help patients understand their illness, to help them identify and manage their needs, including that of a safe environment, and to help them gain some control over both their thoughts and behavior.
And in the psychodynamic treatment of schizophrenia, it's different than the treatment of anxiety disorders. In anxiety disorders, the whole focus of the treatment is on insight, whereas the psychodynamic treatment of schizophrenia, of the schizophrenic, has to do with developing a new parental relationship. It's the relationship, it's the nature of the positive relationship between the patient and the analyst that is curative in this form of treatment.
Some psychotherapists believe that insight is possible, but it's through the therapist-patient relationship that progress is most often made. Dr. Silver's work involves what she calls rebuilding bridges, teaming up with the patient by talking, listening, and being a source of support that remains constant throughout the course of illness.
By and large, the patients I've worked with have been sick for many years. They've worked with many doctors. They've had many experiences of defeat. They've been on many medications, either individually or in combinations, and come pretty much immersed in an unthinkable defeat. And the work that I do is to meet with them and gradually to find a place where we can relate, areas of maybe mutual interest or a gradual development of interest out of fragments of contact. And with the understanding that we may be working together for a very long time, and that if the going gets rough, that's not a reason to quit, that I'm here to go the distance with them.
David was Dr. Silver's patient at Chestnut Lodge.
My relationship with my doctor was one of distrust, admiration, and gratitude, with a slight bit of trust, very slight. It's getting bigger because I'm still in contact with her.
Initially, the patients will hardly ever believe that anything good is going to come of it. Gradually, there's very often a rekindling of hope, and as the relationship with the doctor becomes something that they really feel that they can depend on, that then generalizes, and they'll be more reachable to other people in the community, and then we'll start reaching out to others.
I doubt that at any point research will ever find a single cause of schizophrenia. That when we talk about schizophrenia, we're talking about a complex, multi-theoretical, ideological system. That in some cases, possibly certain types of ideological factors are primary. In other cases, certain other ideological factors are primary. But that this idea of the search for the single cause, I think by definition, will end up being fruitless. What we have to do is get better at doing research on combining theory and combining treatments.
No matter what the future brings in terms of scientific advances, many professionals believe that people with schizophrenia can be helped to live more normal lives in the community.
I think in most any city that you go to, you can identify people with psychiatric illnesses on the street because of how they look, because of how they conduct themselves, because of how they interact, because of how they talk. So we try to teach them the kinds of skills that will enable them to more or less fade in the crowd, into the crowd, in spite of having a major mental illness.
What we hope for with schizophrenia in the current state of the art is effective control, rehabilitation, and management, and that in this sense, the role of the psychotherapist, the behavior therapist, the social therapist, the rehab therapist, all the other social and psychological interveners is important, and that is, even if we take the hard view that schizophrenia is exclusively understood as a biological disease caused by biological factors and maintained by biological factors, nevertheless, there is fairly strong evidence that there are psychological and social interventions which can help that schizophrenic patient, usually in conjunction with antipsychotic drugs, can help that schizophrenic patient to make a better adjustment to the world than was made before.
Yeah, there's been some changes. I learned how to slow down my speech when I take my time and speak slowly, and that's one thing they're working with me. And I was trying to I'm at an age where a man when he passes age 30, he's a confirmed bachelor, and I've been trying to get married, so they helping with me learn how to talk to ladies. And I'm a paranoid schizophrenic progress, and I'm getting better each and every day.
The point I always make with my father when we talk about this is that he says, you're doing so well, you're trying so hard, you're so much stronger now, you're doing so much better, especially that you're doing so much better. And I always tell him, you know, I was always doing better. I was always doing better than anyone expected. I was always doing better than I expected of myself because I was always fighting.
When we say, hey, I'm hearing voices and I'm trying to deal with something and it's ruining my life, or I don't know how to relate, hey, it's happening. And you have to acknowledge that too, but science doesn't want to acknowledge that. And that's part of the mess up in, you know, the way they mess up your kids, you know. You call them, like it said, they called me a Cub Scout. They said I was deluded, you know, and he didn't believe me. You know, I don't know, I hear voices, they come to me.
My parents and I get along very well, and they're all for my new experiment and a new program. And we meet every Saturday at least, and on the phone during the week, in the morning hours. And I like them a lot, and I love them. And they're always do the best for me, I'm sure. And I didn't mean to leave them so early in life. And that, after all, 19 years old could be very young to leave home. Some people don't leave until they're 50, I've heard. And all I know is that my parents and I get along very well together, to make a long story short.
Hopefully, if I can't live out there on my own and have my own individual life, then I will live in a boarding care home where I can build up my own self-esteem, my own life, and try to manage it in a boarding care home setting, a structured living setting, until I can make it on my own, if ever again.
Funding for this program was provided by the Annenberg CPB Project.
To learn more about the Annenberg CPB Channel series and workshops for teachers, how to take them for credit, how to buy them on video cassette, call 1-800-LEARNER and visit us at www.learner.org/channel. The Annenberg CPB Channel.